Okay, fingers crossed. Can you hear me?
Okay. Y- Yeah, I can hear you.
Okay, and there's no delay. Wonderful. I'm hopeless with this stuff. I always get so nervous with this online stuff because it's so hard to figure out what the go is.
I know. I'm so bad with it too. I actually brought my like a light to plug in because the room that I'm in is not super bright, but I think my light being plugged into my computer was messing things up. So,
Ah,
but you can see me okay, right? Like it looks
yeah,
okay?
absolutely.
Okay.
Absolutely. Yeah, perfect. That's a nice little space you're in with a cool old school blackboard and everything. Wow.
Yeah, thank you. This is where I teach classes in Philly, and it's an old school that was turned into like office. There's like offices, and this is the chiropractor's office. There's a tattoo parlor down the hall. There's restaurants upstairs, coffee shops, daycare in the basement. Like it's really cool. It's an old Votech school, so that it used to be like I don't know for what I don't know, like kind of like an alternative high school. So it's
So
cool.
cool. That is so cool. So you do lots of in-person workshops for both parents and birth workers or just parents?
I do. I do it for both parent and birth workers. And so, like the workshop that you took, that one, when I teach it in person, is taught in South Philly, unless I go somewhere. Like sometimes, I travel to teach those workshops, but when I teach them at my home base, it's here in this space. And it's kind of hard for you to see, but it's actually a really big old classroom. So I can fit about 24 people. I mean, it's a little tight with 24 people, but it's a really big space.
So
So,
good. So good. So good. So good.
yeah.
Um, cool. Should we get straight into it then?
Absolutely, yeah. So, I think I had a question for you when I was driving in. I had a question, but I don't know. It's fine. Whatever it is, it'll be fine. I don't remember what it
We'll figure it out on the way. I can always edit it after. Um,
Okay.
did you get
And
it?
just FYI, I have till like 5:30. Is that enough time? Do you think? Is that good?
Yeah.
Oh, well, it's 30. So it's like a little over an hour.
15 minutes. Yep. So that'll take us
Okay,
to 7:30 my time. 8:30. Yep, that's fine. That's fine. That's fine. I reckon that'd be great. Thanks so much for
cool.
popping on, by the way. I've been so excited for this podcast. It's going to be so epic to get out there to the mamas because from all the stuff that you've taught me, I've literally over this Christmas break, I've changed all my body balance workshop, all my birth workshop. I've just implemented so many more extra things and it's just been so nice, learning so much over the last year and then eventuating with the time to be able to put it all into the workshops as like a nice clean cut kind of thing. So it's just been the best reflecting on it all. I did actually go to listen to finally day two of the second workshop that I did only a couple of days ago and it was gone. And I was like, oh no, I was so bummed.
Oh,
Didn't have the time to watch it beforehand. And I was redoing the birth workshop. So I was like, cool, I'm going to watch it now. And then as I watch it, I'll implement it into the workshop. And then, just ran out of time. But I got day one. So that was fine.
oh, I'm sorry. And I do actually like totally delete them because otherwise what often winds up happening is people do reach out like a month or two later and they're like, hey, and then I feel like it's kind of unfair to the people that tried to get it in. So I just delete it that way. I'm not make like doing favorites or something by like letting people watch it later.
Absolutely. Oh, and if
So
you're like me, which I think you are, it'd be like, oh, if the video is right there, I can't just say, no, I'm not going to give you this video.
yes, that's what happens to me. And then I feel bad because some people probably are like, oh, it wasn't there. And then I never hear from them and they never watch it, but they could have watched it so I just feel like it's easier to just like stick to what I say. And I actually lengthened the amount of time. I used to allow only 2 weeks to watch it. Now I allow a month to watch all the recordings. But
Yeah.
I'm happy to answer any questions you have today if there's anything that you
I
were
do
hoping
have
to see there.
I do have these. Cool. Well, I'm gonna hit record in a sec, and essentially, I think we'll just get you to say like what you do and how you got here, and then yes, I do have a bunch of birth and positioning and stuff questions. So
Wonderful.
let's get into it. Thank you so much for jumping on the podcast, Britt.
Thank you so much for having me. I'm so excited to be here. Any chance to talk about the pelvis, I'm in.
Absolutely. Me too. Me too. Amazing. So I discovered you. I can't even remember how I came across you. It was last year. Actually, no, it was from the evidence-based birth podcast. And
Yeah.
listened to it and I was just like, oh my gosh, these are literally the questions that I've been wanting to have answered for so long and couldn't find anything out there. And then came across your podcast and I was just all bloody about it with the dynamics. I really like putting logic behind, intuition or the woman's body and what it's telling it, and then finding out the actual logical reasons as to why they do it, which I feel like you just answered so many of those questions. So then I've done a couple of your workshops last year, which were amazing, and I'm so stoked to get you on for the Mamas today.
Thank you so much. Oh my gosh, everything you're saying is so true. I mean, there's so much intuition behind birth, and honestly, pretty much everything I talk about in my workshops is like, you actually know how to do this. But the thing is that our big thinking brains get in the way, and if we're not used to completely tapping into our bodies for labor and birth, then our brains are going to be like, whoa, wait a second, this position seems crazy, or this is not something we do on a daily basis. And there's no familiarity, there's no muscle memory. And so by understanding, just like you said, the logic behind it, the why behind certain positions, it puts our thinking brains at ease and allows us to more easily tap into that intuition. And then I think as birth professionals, it's so important for us to understand why, because if we're sharing that information with clients, we need to be able to explain to them why what we're suggesting is completely different than anything they've ever heard before.
Yes.
So that why is so important.
Absolutely. And I actually find that with myself, but also with the parents and especially the dads that I teach, that if you just say a fact like, if your mum gets an epidural, do this. If she does this, do that. But if you can, they really struggle to hold on to those facts. However, if you explain it in a story, which is like explaining why that happens, when the woman does this, it means this is happening with the pelvis, so therefore we do that. It really sticks in their head and my head a lot more rather than just X plus Y equals Z. It's like remembering an algorithm is so much harder than understanding how to actually get to that end result.
Yes, 100%. And when I teach workshops to birth professionals, primarily when I'm teaching to like nurses, sometimes a really common response that I get is, well, all my patients are reluctant to move. Okay, so we have to meet people where they're at. We need to explain to them why movement is important. And some people will be like, oh, okay, for comfort. Well, that makes sense. But other people are going to be like, I don't care how my birth goes. I have no investment in the process. I don't care. So why would I move? Well, it's also really, really good for the baby. So I think for most people laboring, even if they don't care at all how their birth goes, when they recognize that movement actually allows for better oxygenation of the baby, then they're like, oh, okay, I'll try what you're suggesting. So when nurses are trying to incorporate movement with clients that might be reluctant, again, understanding the why behind it, not necessarily the biomechanical why, but although that's part of it, but also understanding the benefits and how so many, I would even go as far as to say all of the benefits of movement are things that are going to be beneficial for both unmedicated births and births with epidurals.
Yep, 100%, 100%. Absolutely. Yeah, that in itself, actually, I remember when, you started talking about that, the whole movement with epidurals and how we can still have these, more natural births with an epidural. That was a concept I had never, ever heard of, considered, thought of, and I was just mind blown in that moment. I was like, that's so bloody true. Like, there's no right or wrong. If you want to get an epidural, get an epidural. However, it doesn't necessarily mean that we have to, sky high the rate of you having an instrumental birth or a cesarean section. Like, if you want the epidural, we can still try to work really, really hard to try to get you to push baby out on your own. For the sake of the health benefits for both you and babe. So yeah, that was a concept in itself, but we will get into that a little bit down the track. Get too ahead of myself. So,
I can derail. I can derail and go off onto things all the time. So I will try to follow your lead.
Especially when I'm excitable about the whole topic, I'm just like, all right, keep it cool, Lance. So do you want to start by telling us how essentially you got here in the first place and what you do at the moment right now with your business, with your life, with everything like that?
Yeah, sure. So I'll try to keep it short. I have been doing birth work for over 15 years out of the Philadelphia, Pennsylvania area in the United States. I teach childbirth education classes to expecting parents, and then I also teach additional classes like infant care basics and lactation classes. And then the other kind of piece of what I do is pelvic biomechanics trainings for both clinical and non-clinical providers. So for clinical providers, that incorporates obstetricians, midwives, midwives, nurses, and then non-clinical support would be doulas and childbirth educators. And then I also teach pelvic biomechanical workshops for parents too, but that kind of falls under the umbrella of my childbirth education. And yeah, I'm really totally honored to be able to travel and teach to practices all over the country. I'm so excited to be able to bring this information international, especially with virtual classes and trainings. I mean, that's really opened things up in a way that was not even possible. No one was even thinking of, a few years ago. And so I do that. I do pelvic biomechanics trainings. I do childbirth education. I am also a doula, so I attend people in labor. I don't do as much of that now because I do a fair amount of traveling and it prevents me from being on call. But I miss it when I'm not at a birth for a while. So I try to get in several births a year, if not more than that. And yeah, like I said, I've been doing it for over 15 years. I think the first 5 years or so, I really went heavy into doula work. I did a ton of births. I was on call pretty much all the time, and teaching a lot of childbirth education too. And after having my second son, I was going to take some time off from doing doula work. So I started teaching these really short 2-hour workshops just about incorporating movement into birth. And it was intended for doulas in a sense of kind of passing the torch. I wasn't going to be attending births as often. And these workshops, they were never done in 2 hours. There was so much discussion and so much practice, and 2-hour workshops were really taking 3 hours. And so I started increasing the amount of time. And then the workshops over the past 10, 11 years have really just grown so much. Now they're full day, 8-hour workshops, and they have contact hours approved some of my workshops have contact hours approved by the American College of Nurse Midwives. And then other workshops have contact hours through the Pennsylvania Board of Nursing. So they've really come a long way. And it is in my long-term goals to create a weekend-long, retreat style workshop around the pelvis. But I have a tendency to put together some really, really long to-do lists, and I have to get better at kind of figuring out what is top priority.
Oh, the priorities are so hard. I know. You want to just do it all.
Yes, that's the thing. I have an idea and I'm let me write that down. And then I look at my list and I'm oh my gosh, there are not enough years to get through this. And then I just personally, on a personal note, I have 4 kids now. So my oldest is 16 and I started doing this work soon after he was born. And then my next one is 10 and then my third one is 7 and the baby is about 18 months. And that's it. We're done. We're done. Now I'm on a recording saying that we're done. So it has to be, I have to stick to it. My husband will kill me. And we live in New Jersey, which is really close to Philadelphia, Pennsylvania. That's
I love that. I love that. And were all your babes home births, hospital births, or?
Good question. My first son was born in the hospital and I did not have the experience that I expected it to be. And I felt the expectations I had for my providers were not in line with what they were used to doing. And I didn't realize that until it was really late in my pregnancy. And I finally started kind of demanding answers to the questions that I had. And then I really spent the last few weeks of my pregnancy really stressed out, realizing that they were not on the same page as me. And I thought I had done a pretty good job choosing a provider. I really was very thoughtful about who I chose, but I really did not understand the system in which I was birthing. And that threw me for a loop at the end of my pregnancy. And so my first son was born in the hospital, and then my last 3 were all home births.
Wow. Amazing. Was the first birth, did it kind of end up going to plan like you had hoped, or was it?
No, no, not at all. I somehow squeaked by with a vaginal birth, which in hindsight was great because that prevented me from having to go the whole VBAC route and, finding support for VBAC. Not that, the support is out there and I'm a huge proponent of VBAC, but it's so hard to find providers that are truly supportive of vaginal birth after cesarean. But no, my first birth was actually, we planned to go to a birth center. I took castor oil to induce labor at 42 weeks because if I didn't go into labor by 42 weeks, I wouldn't be able to birth at the birth center. And then my labor was very, very long and very drawn out. And we eventually transferred to the hospital and I had a fever and I wound up getting an epidural. And then 3 hours later, actually managed to somehow push out my son. And I only say somehow push him out because I really, the cards at that point were very stacked against me. It just was not going as I had intended at all. And so somehow I feel like that I'm very lucky that it wound up happening vaginally, because it could have been a whole other set of factors up against, stacked against me in future births, if I was having to have a VBAC.
Wow, interesting.
Yeah.
I usually do birth stories on the podcast, just a heads up. So that's why I guess I'm probably asking these questions. But I'm just interested. Castor oil. We haven't used castor oil ever to induce babies. Like, I heard that's a bit of an old school thing. Was that more common 16 years ago, or?
It's interesting because in our area, among certain providers, it is a fairly common thing to recommend if someone's either getting very close to induction, or if someone's water breaks and they're not yet in labor. It's not by any means it's not something that I've never seen a hospital-based provider recommend it. But it's in other settings, it seems to be somewhat, maybe not common, but common enough that, that it happens. And there is some research that suggests it can be helpful at starting labor, but the downsides are that it can cause dehydration, and because it causes diarrhea more often than not. And initiating the labor process, having had hours of diarrhea and dehydration is not ideal, but I think for a lot of people, it's like being stuck between a rock and a hard place when they make that decision. And then it's just weighing out risk and benefit for the individual and seeing what feels right to them.
Absolutely. Oh, how interesting. Okay, so I feel like a good place to start this workshop is for you to talk about the whole idea of optimal fetal position, because I was like 1,000,000% behind the fact that LOA is the optimal position for every single woman. And then doing your first workshop, I was just like, well, mind blown. Okay, I've got to change all my shit. And it's been huge, and it makes so much sense. It's one of those things that when you hear the fact that, of course, every single woman has a different shaped pelvis, so therefore every single woman should have a different optimal position of their babe. It makes complete sense, but it's one of those things where you're like, how did I think that before? It's so surprising when you actually realize it. So do you want to talk to that a bit?
Yeah, sure. So how many hours do we have to talk about this? Because this is so fascinating to me, because as you know, I teach a really long workshop that kind of like explains the historiographical context for the development of this idea of pelvic shape classification and then the subsequent development of this idea of optimal fetal positioning. So it's something that we could really, really go in depth with, but I'll try to give a synopsis of it that speaks to the point that you're kind of asking about. So there's this kind of continuing to be this perpetuation of this idea of pelvic shape classification. And in fact, pelvic shape classification is not supported by research. This idea that pelvises can be divided into 4 basic categories, this is not supported by research. And this was a concept that came out in American obstetrics in the early 1900s and really took hold, despite there, even at the time, being no well-done research on pelvic shape. But now, at this point in time, we have a lot of research that's come out from not only obstetrics, but also anthropology that actually says there's no pelvic shape classification. There is such wide variation in pelvic shape that we cannot even classify pelvises into 4 basic shapes. But if we go back to that false theory of pelvic shape classification, that false theory divided pelvises into 4 basic groups, and the theory said that there was one pelvic shape that was ideal for birthing babies, needed babies to be in this LOA, left occiput anterior position. And so because there was this one ideal pelvic shape for birthing babies, and then there was this one ideal position for babies to fit into that quote unquote ideal pelvic shape, this theory of LOA positioning really took hold in the late 1900s. And really particularly among the midwifery community. It's not something that we saw quite as much among obstetricians. Obstetricians' focus was not quite as heavily on, necessarily support, that's not the right word, not necessarily as, if things didn't wind up in a vaginal birth, they always could go to a cesarean, basically. Like the tool of the obstetrician is the cesarean, which is great when we need it. When we need a cesarean, absolutely. That's a really important thing. But then when it has the potential to discount things that could potentially increase the likelihood of a vaginal birth, if we know we could always go to a cesarean. But anyway, that's a whole different hole to wander down. Okay, so
preface it.
So going back to this false theory of pelvic shape classification, 4 basic pelvic shapes, one of which is ideal for birthing babies. And this is not true, but this is what the theory is. And what's so interesting is that because this theory said this one optimal position for babies to be in, that ideal fetal positioning also started to be applied to other pelvic shapes. So even though within this false theory of pelvic shape classification, there are 3 other pelvic shapes that did not favor the LOA position, it was believed that babies should be LOA because it will still make for the easiest way for a baby to move through the pelvis. So total disregard for any sort of variations within the pelvic planes. And this is where that idea of cardinal movements of birth all kind of grew out of as well. The cardinal movements of birth always begin with the baby in the LOA position as well. But anyway, again, let's not digress. So this theory of optimal fetal positioning really went hand in hand with this false theory of pelvic shape classification. Now we have this newer research that has come out that says there's in fact no way to classify pelvises because there's such wide variation in pelvic shape. And when there is such wide variation in pelvic shape, that also then means that there cannot be one optimal position for all babies to be in. The optimal position for a baby to be in is in relation to the pelvic space available to them, not specifically one position that we should then say all babies need to be in. And this is what kind of is my driving force behind understanding the biomechanics of the pelvis, how we can create space changes within the different planes of the pelvis. Because when we realize that optimal fetal positioning is based on this false notion of pelvic shape classification, realize that they're not evidence-based theories, it opens the doors for us to be able to utilize biomechanics universally in all births to support babies in whatever positions they are. For example, if we have a baby presenting posteriorly, but we know how to shift space at the sacral promontory, then that posterior baby is not malpositioned. They're positioned potentially how they need to be, and we have the tools to help them navigate that space. So that's a nutshell. But I can go more in depth if you'd like.
Oh, well, that's so interesting. Like, even the idea of, and I know we did the whole workshop on it about posterior position babies. And correct me if I'm wrong, but essentially plenty of babies are actually meant to be in a posterior position, even if everything's balanced in the uterus and the pelvis. Because of the shape of the mum's pelvis, that baby actually should start labor in the posterior position because that's how they need to navigate their way through. But then we can also have babies who are in posterior position during pregnancy who aren't necessarily meant to be, and that can be due to things like imbalance in the ligaments or slouching and leaning back a lot in pregnancy, et cetera, et cetera. Is that right?
100%. Yeah. Just like we could say, we could have babies in the LOA position, and that can be really fantastic. But there's also going to be people whose babies are LOA and their births don't go, smooth and swift and efficient. Totally. So it's the same thing. Yeah. Same thing with posterior babies. So we're not trying to discount the role that soft tissue plays at all. I think balancing and aligning soft tissue and paying attention to pelvic floor health. And of course, if we have too much tension or too much laxity in different areas, or if we have, too much tension around ligaments that can alter the way the uterus lies, sure, we can end up with babies that are not ideally positioned for the pelvic space available to them. But every baby that is positioned posteriorly is not quote unquote malpositioned. That baby may very well be positioned just as they need to be for the space available to them. So in birth, what I really love to focus on is understanding how we can both lengthen and release the pelvic floor as well. And I'm not necessarily saying I'm not actually at all saying with body work techniques, but more so with the positions that people assume in labor. And then also create that space for the baby to descend and possibly rotate. What research does tell us is that most posterior babies do rotate. But again, we need to be able to give them that space to do so efficiently and effectively.
Absolutely. Absolutely. Well, seeing as we're on the topic, another question I had was about posterior position babies. if your baby is meant to be in a posterior position, and one of my mums, for example, this is her third babe, and all her babes so far have been vaginally birthed posteriorly. What would your biggest tips be if you've started labor and you've got a baby in a posterior position?
Yeah, number one thing that I tell people, and this is actually regardless of whether their baby is posterior or not, but the number one thing I tell people for the earlier part of labor is actually to not lean forward all the time.
Yeah.
To spend some time semi-reclined and some time doing pelvic tilts, because when we do that, we shift this problem out of the way. And it's not a huge movement that happens. We get maybe about a half to a centimeter of additional space, depending on somebody's own flexibility. But a half a centimeter or a centimeter, when you have a baby's head trying to navigate their way down and out, makes a huge difference. Yeah. So I would suggest actually some time in semi-reclined positions or pelvic tilt positions, resting back in the bed, resting back on the birth ball with some support behind you, like a partner or, doula friend behind you. And particularly if somebody's baby is posterior, because research does suggest that babies have a tendency to rotate clockwise, we actually may not want to spend time in all fours positions if the baby is posterior early on in labor, because babies tend to begin, when they're posterior, they have a tendency to begin along the right back of the laboring person's body. And then what we wind up having is gravity kind of work in the opposite direction of the rotation that the uterus is encouraging. And so when we have somebody with a posterior baby who spends so much time in all fours, because it does take some pressure off the back, we may actually be lengthening the amount of time standing in labor because and the uterus are kind of working against one another. So absolutely. I would say get the sacral promontory out of the way. That's the number one thing. And if the baby really posterior, then I would suggest probably avoiding all fours or only doing it here and there when you need a little bit of relief on the back, but then trying to spend more time in upright or even reclined positions earlier on in labor. And I know for some people that are listening, they're probably like, what? That's crazy. Because I remember in my in the trainings that as a new doula and new childbirth educator, oh my gosh, it was all about forward leaning, always forward leaning. And then when we actually begin to understand the pelvis, wait a second, that's not always going to be the best way to position oneself.
Yes. Yeah. And in conjunction with what you were saying about the uterus contracting clockwise, I think you said it was clockwise, wasn't it? Yes, like the combination of those two things together is just so interesting. And that's something that I've tried to explain to my mamas, but it is really hard to try to explain to then use in the birth suite. However, as you say, feeling where you're feeling the contraction. So if you're feeling it in that back right hip, or if you're feeling it right on that sacrum or on the left, like kind of listening to where you're feeling that as to where the position of your baby was. I thought that was so interesting when you said that, and where you feel those positions kind of leaning in that direction to help use gravity for babes to rotate around to the front, and they almost always take the long way, as you were saying as well. So I used to always be like, cheeky baby, what a stitch up. But it's the uterus, the way that it contracts. It just has to move that way. That's good of the baby to be moving that way. So I just thought that was so interesting as well. Posterior positions.
I know. I always tell people I have such a soft spot for posterior babies. I think they get a bad rap. People don't understand how to support their navigation of the pelvis. And so there's definitely this idea that like a short birth is ideal. And I would argue that that's not the case. But with that very commonly accepted goal of this short birth, then we begin to think that, well, that posterior baby should take the short way around. But if we're thinking about it from a space standpoint and from the rotation that the uterus is encouraging, that baby is actually more likely, just like you said, to take the long way around. So we need to take that into account. So often we think of when we're thinking about positioning of the person laboring, so often we're only thinking about that. But the baby has all of these movements and shifts that they're making as well. We have to be able to put all the pieces of the puzzle together in order to really understand what's happening and facilitate progress in labor. And it's interesting, just to tap onto one of the things that you said. You mentioned how you might experience back pain along the right, and then more centrally located in the sacrum, and then along the left. And I know for some people, I think sometimes, just based on the responses that I've got, sometimes people are like, I don't think it's that easy to distinguish. It actually almost always, in my experience with clients, is. Like when I ask people where are they feeling discomfort, and they say in their back, I usually ask them to specify, are you feeling it on the right or on the left or in the middle? And they can usually say, I feel it more on the right, or I'm feeling it more on the left. And then when it shifts, they notice that. They notice that it's no longer on the right, now it's on the left.
Wow.
And it's just about kind of, again, helping people to, yeah.
Yes.
Pretty
So
cool.
interesting. So
helping people tap into that intuition, like what are you feeling?
Absolutely. And of course, they're going to say on their back because they're not knowing how specific you're wanting to get it. But sometimes you just need to kind of nudge that little bit further to get that more specific response. Like we can't just, ask one hard and fast answer and be like, oh, they don't know. So in regards to creating space and the actual way that baby descends through the pelvis and rotates, what's your thoughts on a baby being deflexed or asynclitic? Because I know that you mentioned in your workshop about as baby descends through the pelvic floor, it's quite a normal thing for baby to turn asynclitic for a moment. So for mums in the birth suite who maybe get told that after a vaginal exam, what should they think or do, or what's going on there?
Really don't like the word malpositioning. And when you look at research on positioning of babies, the word malpositioning is used all the time, and it's used to describe babies that are posterior or asynclitic or babies who have an extended head. And again, when we look at the baby's role in birth and how actively involved babies are in the process of birthing themselves, we realize that they naturally are going to extend their heads or tilt their heads at different points as they respond to tension and laxity in the pelvic floor and as they navigate the bony structure. So when I'm thinking of an asynclitic baby or an extended head, I'm never thinking like that baby's malpositioned. I'm thinking, let's make sure the baby doesn't get wedged in the pelvis like that. Let's make sure the baby has that space to keep moving, because it's normal to get into that position or that presentation, but it's not necessarily great if the baby is kind of staying like that for an hour and 2 hours and 3 hours. And we have these strong, long contractions, but no progress in terms of rectal pressure or descent of the baby. Yeah. Then, maybe they're wedged in that position. But the fact that they got into that position in the first place, that in my mind is a problem. That's a normal part of the process. It only becomes a problem when they have space to keep navigating downward, if that makes sense.
Absolutely. So would you, because I teach in my workshops, which is what you told me about the whole rectal pressure depending on what plane of the pelvis they're in. So depending on whether you're feeling that rectal pressure or not, would you, if your babe was asynclitic or deflex, you would work on really going hard at the positions to create space in that plane of the pelvis that babe's in? We're a bit frozen. You hear me?
I can really subtle. And
sorry, do you mind starting that again? It just wigged out a little bit.
Yeah, no, that's okay. That's okay. So I love reminding people that movement can be really subtle. It does not have to be dramatic. So again, like if somebody has pain medication, they can incorporate lots of really effective, subtle movements. But I also love to add that if we know baby might be having a challenging time at a certain point in labor, or if we know like, okay, baby's rotating through the mid-pelvis at this point based on the amount of rectal pressure someone's feeling and or an internal exam, the more dramatic we can make the laboring position, the more space change, the greater the space change we're going to give the baby. Yeah. So if we are able to really hike the leg up into a lunge, let's make sure we're doing that. But if we can't, for mobility reasons or flexibility reasons, we just do what we can. But the more dramatic the position, the more dramatic the space change. So particularly when we're working with a scenario where a baby may be more likely to get kind of wedged in a position, which happens sometimes as babies navigate that mid-pelvis and they're rotating and they turn their heads and then they tilt their heads to the side and sometimes they extend. And now if we don't give them dramatic space changes, we might wind up with a baby getting wedged. Yeah. So the more the areas of the pelvis that tend to be more narrow, and again, there's wide variation from person to person, but we do know that the pelvis is most narrow at the mid-pelvis for most people. like just in terms of the dimensions of the pelvis, it gets more narrow at the mid pelvis. Babies are rotating at the mid pelvis. So let's make sure at the mid pelvis, we're doing some really dramatic asymmetrical positions to kind of work with or give the baby that space to move out of asynclitic positions or extended head positions.
Amazing, amazing. It's so nice to have an answer because, like, yeah, I have heaps of mamas that come and say that that was an issue in their birth, and kind of they hear that and they think, all right, tapping out, like, babe's going to get wedged. This labor's not going to move forward. I'm going to end up in a Caesar. But as you say, it can be such a normal position to resume for a moment in time. Let's just create space to let baby click back into place and then continue on their way. And yeah, that's so relieving, I think, for mamas to hear that, oh, like, even if that happens, not the end of the world.
Yes, absolutely. And I think I work a lot with people who have done like at least a little bit of like searching online for things related to birth in preparation for their experiences. And quite often the things that I find my clients getting hung up about a lot are positioning issues with the baby. And so when we talk about what the research actually says and what the physiological process kind of entails with babies' dynamics, it really does give them a sense of relief, I think. Like it takes off a layer of anxiety when they realize like, oh, I don't have to be fearful of my baby getting wedged in, with their head tilted to the side. I don't have to be fearful of a posterior baby because I know how to work with that. And I would argue too that goes for providers. When a provider has the skills to support a baby who may be positioned posteriorly or asynclitic or extended head or compound presentation, the provider is relieved from an extra layer of anxiety because they have the skills to work with it. And so that's huge.
Totally. What was I going to say about that? Anyways, I'll move on to the next question because it'll probably pop up. I'm intrigued, and this is probably more for me, but with your birth education towards mamas, so you do birth education with parents, and we all know that when we go into labor, the mamas often get into that reptilian brain and their logic's not there. They're not discerning, oh, wow, I'm feeling pressure here, so this means that I need to do this, right? So how do you go about giving that birth education in a way that mamas are going to be able to utilize in labor? Plus, how do you, what's the biggest things you teach dads for labor? How do you go about teaching them the most important things?
Yeah, that's a great question. So I really do emphasize the importance of support. So when I teach childbirth education, the cost of my class includes the person giving birth and a support person. And if somebody's like, well, I don't have a partner, so I'm going to come solo, I encourage them to bring somebody that will be at their birth, whether it's a family member, friend, doula, whoever's going to be supporting them, because just like you said, the person laboring should not be like, well, I think my baby's here, so I should do X, Y, Z. No, you don't want to have to think about it when you're in labor. And yes, it's very intuitive and instinctive, but it's also kind of methodical when you think about the series of positions that may give the baby the space they need. So we don't want to have the person laboring using their thinking brain at all. So I really do aim a lot of my discussion about movement and positioning at partners or support people. Like, you guys are going to be the ones that are guiding them through movement. So it's really, really important that you remember what positions may create space at the top versus the middle versus the bottom of the pelvis. It's really important for support people that you communicate with them. Where are you feeling pressure? Or are you noticing that they're going to the bathroom a lot? That's going to indicate that possibly there's rectal pressure. So notice those little tiny kind of signs that things might be happening and hone in on that. And I also really, one of the things that I really emphasize for support people is that sometimes in labor, this is not necessarily related to the pelvis, but sometimes in labor, you will feel like you're doing nothing and you are still extremely valuable. Don't leave their side, because even though they may not want you to touch them or talk to them or do anything, the second you go to the bathroom, they're gonna be like, where are they? I need them back. And so it's like, don't leave their side and don't underestimate just simply the importance of being present. I mean, we see that with doula research, that even just having somebody sitting in the room with you consistently through labor, that can decrease intervention and that can improve birth satisfaction, even when the person doesn't do anything. So that's the thing that I emphasize.
Absolutely. Me too. Massive advocate for that. Just being present. So she knows that when she wants you, you're there. There is nothing more comforting and safety than that for the mum. Absolutely. That's interesting. How do you when, like, I guess this is more of a doula question. When you're looking after your mamas in transition, what's your biggest tips to help them get through that transition? And I've actually also got an interesting question for you, and I'm intrigued on your opinion. So they, okay, so birth is the most intuitive thing, right? Everything happens for a reason. So, every position that we'd be like, oh, I wonder why mamas get into that position. We realize it's to create space in a certain plane, etc. So I'm a massive believer in everything that happens in birth is for a reason. Why do you think, evolutionary speaking, we go through this wild hormonal response in transition where we feel like we're going to die and we're so fearful, we're so doubtful, we're so afraid? Why do you think that happens?
That's a really good question. So no one has ever asked me that before. And I like that. And I like that you're putting me on the spot with that question. And I had no idea that was coming. So let me think.
I literally didn't even plan it either. It just popped in my mind then.
It's a great question. I'll answer that and then I'll go back and answer what you were asking before about transition. So off the top of my head, I think my response is that at least okay, so based on what I share with people when I'm teaching classes, I look at transition as this like total identity shifting place in labor where you're forced to let go of your ego, where you are literally like walking this fine line between like really between worlds, where you're like totally your whole everything that you are about just kind of has to go by the wayside. Like there's no holding on to your ego. There's no holding on to your expectations. You just simply have to let go. But you have this weird kind of dynamic of having to let go, but also needing to retain some sense of control so that you don't feel like you're suffering, right? We don't want people suffering through transition. And although I totally agree with you that transition is like the most challenging part of labor for most people, and I know in my birth, transition always felt really crazy, no one should feel like they're suffering through that either. You can feel like this is totally crazy and also feel like, but I can manage it. And I think transition really sets us up to come out of it feeling like I could do anything in the world. Push a baby out, no problem, because you just got through this crazy town of transition.
Amazing. That's so cool that you say. I love that. I've got goosebumps at that identity and ego shift. It's so true because as they say, you're birthing a baby, but you're also birthing a new version of yourself through every single birth. And especially that, 0 to 1, like you're transitioning from maiden to mother, like you are totally changing your whole self. But that's funny you say that because I agree with the part about it's so hard, but I think that that's almost setting you up for the difficulty of being a parent, like which is obviously the challenge of all. So that's really interesting, putting you through that hardship so you do have the sense that I can do anything now.
Yes, absolutely. Absolutely. And you literally come out of transition like a totally different person. The birth process itself changes you, but in terms of like how your identity shifts through that laboring process, I feel like transition, it forces you to just like dig deep and realize that you had reserves that you never even knew you had. And that's really powerful.
Amazing. Amazing. Yeah. Yes.
I also, just a fun side note, I always tell people in my classes too that like as a doula, transition is super fun and amazing because we see this person going from this very kind of zen, like very rhythmic state of active labor into this totally primal, like tearing off their clothes, dry heaving, water might be breaking, like totally intense primal part of labor. And as a doula, I'm always like, oh, this is so fun. And then of course, as somebody who's gone through it, I don't feel that way necessarily when I'm going through it. But as a doula, it's so exciting because you can just see like all those layers just coming off. Like the primal part is it's just there. It's just coming out. It's amazing.
Probably the most natural thing you could ever see, I reckon, transition. It's just like the most, animalistic, intuitive thing in the world. It's amazing. It's amazing.
Yeah, totally.
Cool. Cool. So how do you like guide your mamas and support a mama as a doula, but also in your workshops, how do you tell them so that they can feel like they're managing it, as you were saying? Because I think a lot of my mamas, they have a really hard time in transition.
Yeah, transition is really tough. And I think, again, it has to be in order for that identity shift to happen. Like our identities don't just change when, with like your average day-to-day activity. like it has to be a powerful, emotional, physical experience that really changes who we are. But yeah, I mean, it's such a challenging part of labor that it's really difficult, I think, to truly have someone understand, just in talking about it or practicing positions for it or practicing comfort techniques, to truly understand what it's like. But I do remind them of a couple things. Number one, that for most people, and doesn't apply to everybody, but for most people, transition is the shortest phase of labor. And although this could work in your favor or not, your sense of time in transition, it has really changed because there's very little thinking brain activity going on, if any. So like, even though it's the shortest part of labor, you may have like literally no sense of how long you've been in transition because it's just simply contraction and short rest, contraction, short rest. So I think reminding people that it's the shortest part of labor, but also you have no sense of time, which can work in your favor. That's really important. I also remind people that the things that further disengage the thinking brain and take you to that primal brain, that's what's so important to hone in on transition. So we're talking about rhythmical movement. We're talking about submersion in water, like getting into the tub or the shower if a tub isn't available. I often support people that sometimes if the person is in transition and like maybe back pressure was working so well through most of labor, it's probably not going to work anymore. And that's okay. Like they might not want to be touched. They have to dig deep and find those reserves inside themselves. And I also really encourage people to embrace all of that intensity, like recognize that this is what's taking you through to the other side. And then when it comes to things like nausea and dry heaving, which are so common in transition, my favorite thing is to help people change their perspective on what they're experiencing. And nausea and dry heaving, like that's a great way to move the baby down. Every time,
Yeah.
like the baby shifts a lot.
Yeah.
So it's all about progress. So that's important. And then if I was to give somebody like one specific technique that I would say is really important in transition, asymmetrical movement. If we can incorporate asymmetrical movement in transition, that's so helpful because babies tend to be right around the mid-pelvis in transition. The baby is probably shifting, descending a little bit. And if we can really do asymmetrical and rhythmical movement through those contractions, it will help to move that person through transition a little more efficiently. I like things where we're like, I'm sorry, what did you say? I missed that.
Sorry, just amazing. Love it.
Oh, yeah. So things like lunge positions, or even better, like walking lunges, or like maybe not lunging like you're exercising, but raising your leg up, rotating it in circles, doing it on the other side. That type of movement is going to be so helpful through that phase of labor. Intense, and I'm not saying it's easy to do, but it will help that part of the labor to move a little more efficiently, and it gives you something to focus on as well. When people lock up and they don't move and they're hunching their shoulders and they're like pulling up onto the balls of their feet, that's tension in the body, and that's only going to make things feel worse, and it's probably going to make that part of labor happen take longer. And so if we're able to sink into the contraction and rock the body, even though the idea of that might be so daunting, it can be really helpful for progress, which means getting past that part of labor a little more quickly.
Amazing. That's such great tips. That's actually something that now I do recommend as well, is, as you were saying, getting into that reptilian brain, doing what you can, and as the support partner, doing what you can to get her back into that reptilian brain, out of freak out mode, even breathing with her to get her back really in tune with her breath as well. So beneficial. That's really, really interesting.
Absolutely. And breath can be such a good focal point. Even if person's experiencing a lot of discomfort, and movement is such a great way to decrease anxiety levels, decrease the release of stress hormones, and again, just like help someone feel like they're able to embrace and move through what's happening rather than kind of fight it. And our tendency when we're feeling a lot of pain is to, in life in general, is to hold our breath. We tend to tense up and hold our breath. And sometimes just simply that reminder to do long, slow breaths is enough to release a little bit of tension in the shoulders and a little bit of tension in the back and a little bit of tension in the pelvic floor. So yeah, the breath thing, I totally agree with that.
Amazing. Okay, I have two more questions. In regards to an induction, and I'm interested in the differences between Australia and America because so we use syntocinon, which is similar to your pitocin. And the thing that I personally find is the hardest thing about induction with my ladies is that they get induced for whatever reason, which is fine, but then we turn up that drip every single half an hour until they're contracting 3 to 4 contractions in 10 minutes. And first of all, I feel like a lot of the time having 4 contractions in 10 minutes isn't necessarily normal. Like a normal labor, it would be somewhat rare to have 4 contractions in 10 minutes, I feel. But then in addition to that, I don't know how effective we actually are testing the contractions or if we're actually giving the body enough time to respond to the increase of the drip before we're turning it up again. And then the women hyperstimulate and then that cascades into a whole bunch of drama. What's your biggest tips to induction? And do you find that happens the same where you are, or what's your thoughts?
Yeah, it seems really similar. We usually say that with pitocin, which is what's used here, in contractions, the goal is to get contractions to being about 2 to 3 minutes apart, full minute long, which is very similar to what you just said, 3 to 4 in a 10-minute period of time. And the concern in my mind with that, just like you mentioned, is that that's like transition. And for somebody to have contractions like that through the duration of their labor can definitely set up the cascade of interventions, whether it's due to distress in the baby or hyperstimulation of the uterus, can absolutely increase somebody's likelihood of getting pain medication, which brings its own potential risks. So it sounds like it's very similar to what happens here. There are 2 things that I really think are important to remind people with induction. Number one, you have a voice. So the entire, even if like the induction was not the original plan and now you're like, oh no, I have to have this induction, you still have the right to ask questions along the way, to gather information, to be part of that decision making. And sometimes I think when things don't go according to plan, people feel like now all of a sudden they just have to throw all their preferences out the window. And that's not the case, So I really remind people that even if things are not going as you had hoped, or if you're, accepting an intervention because you feel comfortable with it, either way, you still have the right to ask questions along the way. And what research based on surveys that have been done tells us is that it's less about whether something goes according to plan, but actually more about whether someone feels in control of the decision making as to how positively they look back on their birth. So when they feel like they were part of decision making, there is improved birth satisfaction, even if birth did not go according to quote unquote plan. And so I really remind people of that with an induction, because like you said, it can wind up leading to a lot of drama. Things can happen quickly in an induction. So let's head that off from the start by asking questions along the way and making any preferences we have known so that we're part of what's going on rather than feeling like something's happening to us. Yeah, and was there a second part to your question? I feel like I kind of went.
Yeah. No, I think that's it. So your biggest tips for an induction to kind of not run off with that cascade of intervention would be to be the primary decision maker and still make your preferences clear.
Absolutely, yes. And then, of course, because I can't not say this, incorporate movement. Like, remember that movement is important. And movement is important even in induction. But let's say somebody's being induced and they decide to get pain medication. We're kind of circling back to what we said in the beginning. Movement should not stop just because an epidural was given. And I know, nurses can't necessarily be in the room the entire it would be impossible for nurses to be in the room the entire time supporting movement, but there are props available, things like the peanut ball. And when support people can rock the peanut ball or help someone shift how their legs are positioned, even something as simple and safe as that can change space in the pelvis. So there's no reason not to incorporate movement into births with an epidural. So again, if we want to decrease rates of intervention, decrease cesarean birth, decrease risk of instrumental delivery, whether somebody has an epidural or not, movement has been shown to have all of those benefits and should be something that's incorporated. So the thing is that, nurses have to be really well-versed in utilizing effective movement, and support people do too. It's so much better when everybody works collaboratively. If we have a nurse that's really totally understands movement, but we have a support person that's totally reluctant to be involved, then that can be hard. Just like if we have a support person that knows all about how to incorporate movement, but every time the nurse comes in the room, they're like, oh, you can't do that, or what are you doing? Or, we don't do that here. That can be really hard. So when everybody is well educated about the importance of movement in birth, then we can really work collaboratively and really, really begin to see those benefits and even statistical changes in terms of birth outcomes. So
Amazing.
Movement is important.
I
Yeah.
totally agree. That was actually going to be my next question was how to incorporate movement in an epidural or what to do with an epidural. But essentially your answer is move, keep moving.
Move. Yeah, and sometimes, I post a lot of stuff on social media, like videos and things like that, and I get all sorts of comments from people that I obviously have no idea who most of the people are. And people will say things like, you can't move with an epidural. Not true. We're not talking about like necessarily walking across the room, because the way that epidurals are provided here in the US, that's not an option. But we're talking about like rotating the thighs, like having the thighs farther apart versus closer together. That's a position change. Or sitting semi-reclined on the hospital bed versus literally raising the bed so that it's at a 90-degree angle. That's a position change. So it can be so simple and subtle. And I think when people think about movement, they think about big dramatic movements, but simple, subtle, small movements that shift space in the pelvis or shift the way that gravity is working on the baby can make a huge difference. And so, yes, I mean, maybe we can't do huge movements with an epidural, but we can do simple, subtle movements. And I have done with my clients who've had epidurals, I do all fours or kneeling positions on the bed all the time. So I know that it's possible. It is possible. Maybe not 100% of the time is it possible, but I've done it. Like I know it's something that can be done. So, epidurals take away that sensation. They don't decrease a lot of the mobility that people have. So we just need to work within someone's limitations and do it in a safe way. And then we realize that movement within the pelvic space can happen even with subtle things like how the sacrum is shifted or how the thighs are rotated.
Yes, amazing. I actually just saw your post the other day, and because I did a bunch of photos for the dad's birth booklet of different positions, and I loved it. So I did photos of this one where you're sitting up in bed and they're sitting on their sits bones, not on their sacrum, and you're kind of sitting how I am now, and literally one leg kneeling up, and then you swap the leg, and then you're in diamond pose, and then you had both legs up, one leg long like this, one leg long like that. It's just that's like 30 or 40 contractions if you're changing every 5 of just in the one position, like actually just moving your legs around. So
simple.
you can absolutely change the movement, change the position, do little rocking things throughout. Like there's so much you can do, and that's such a cool perspective because some people, which it's totally their choice, they just aren't interested in birthing without an epidural. That's cool. Let's still see what we can do to, help you have a normal birth. Yeah. I'm a massive believer in that in my biz. And this is something I'm always reiterating, especially, I don't know about you guys, but here on the coast, there's a massive influx of people free birthing. And yeah, I guess personally, I'm not a huge fan of it, but that's another story. But I am a big believer in we don't have to be 0 or 100. Like we don't have to be 100% natural or 100% medicalized. So sometimes, getting an induction is the safest choice for a healthy mum and above. And the best way to do that induction is to have the induction, but then we can still do heaps of other things to prevent the epidural, the instrumental birth, the cesarean section, etc. So I think it's really important having that balance and constantly having that, like, I guess, responsible decision making throughout the whole process.
Yeah, and yes, I agree with you so much about that because it's about having individualized care, not just saying like, okay, well, 95% of the people who give birth here get an epidural, so we're just going to expect you to get an epidural. Well, how about we meet this person where they're at? Like, let's take things one step at a time. Let's make decisions one step at a time. Let's make sure the person laboring is part of that decision making rather than having these just kind of routine things thrown at them. So I'm a huge advocate of an individualized approach to birth, even within a setting or a system that is not catering to the individual experience. We can still go in as pregnant people, as laboring people, we can go in and demand that our care be provided on an individual basis. But I think it comes down to like a prenatal education piece of it because people don't know. They don't know that they can make requests and share their preferences. And I think, in my area, providers are very willing to work with people that want to do something differently. But if the person doesn't even know to ask for it, then nobody's necessarily going to offer anything different.
Yes, yeah, 100%, 100%. It's not going to be offered or often even asked as a question. It's going to be told, but it's up to you to say, actually, no, I don't want that, even though you didn't ask me, but I'm letting you know or letting them know your preferences because you're not necessarily going to be asked. I completely agree, which can be really hard for people, especially if they're not health professionals can be super duper intimidating, especially when, you have a preference that's against recommendations and then they get, the team leader and then they get the doctor and then they get the higher doctor to all come and talk. It's so intimidating for like even me if I'm a worker saying that this woman doesn't want this, so I'm not going to do it. It's let alone being the woman themselves who aren't in the field. It's super duper intimidating.
Yeah, yeah. And that's so interesting that you say that because there's that peer pressure from within the system of professionals, as well as the pressure that the person who's laboring feels to conform to whatever the kind of protocol is.
Totally, totally. Super duper quickly, because I have a little bit more of your time. I'm intrigued on going back to your birth story, if you don't mind, because this is a big
sure.
that I have with my parents, where your first babe, you got to almost 42 weeks, and were your second, third, and fourth babies, did you have longer gestations with them as well? And that's just how long your body took to cook them?
Oh, I love that question. So my first son came right on 42 weeks. And that was the castor oil experience that I shared earlier. My second son came at 42 weeks and 3 days, without any sort of induction method. My third baby came at 41 weeks and 1 day without any sort of induction method. And then this fourth one totally threw us for a loop, 38 and 5. So without any induction. And I was full on like, actually my water broke first and I was like, oh my gosh, my water broke and I'm going to be pregnant for another 3 weeks. Like, how is this? What are we going to do? And I was like, should we even call the midwife? I was totally, and here I am, like, I know the research. I have trust in my body, and still fourth baby, he totally threw me for a loop. And then within like 2-3 hours, contractions started. And then from like 11 p.m. to 1:30 a.m., I was in labor and he was born. So, it was crazy. Yeah. But so my second son was crazy because he came after my first, like, longer gestation, which I thought for sure he would come earlier. The third one totally, like, kind of caught me off guard because she came a lot earlier, but still like a little bit of longer pregnancy. Yeah. But that fourth baby, 38 and 5, it was crazy.
Well,
so
you also, like, probably with the same partner, I think, had a 42 and 3. Like, that's such a huge discrepancy. That makes no sense in my mind. I find that really interesting. So how did you go about, like, what's your, like, the facts, I guess, the research, and how you went about having the confidence to go past 42 weeks? Do you know the actual stats for, like, a low-risk pregnancy, etc.?
I would have to look into it. I don't want to share statistics that I'm not 100% sure of. I remember for me, I felt really, like, again, going back to taking an individualized approach, the choices that I make in my births are not what I actually don't even share my birth stories with my clients at all. So it's funny being asked about it. I really don't talk about my births that much. But I really try to emphasize the choices that I make are based on my own individual experience and not what I'm recommending for anybody else necessarily. But for me, I really trusted in my body. I knew that my pregnancies were healthy. I was really conscious of, like, eating well and exercising and, like, just very, very conscious of, like, doing the things that were within my control to grow a healthy baby and have a healthy pregnancy. And for me, the potential risks involved with something like induction outweighed the benefit. In my mind, like, we hear scary statistics, we hear things about increased risk of stillbirth, and we hear things like, again, like, I don't know the statistics off the top of my head, but we hear about, like, the scary numbers. But then the other thing that we have to do sometimes, just to, like, see all sides of it, is to flip it. So, like, if we have, like, let's say we have a 2% chance of XYZ happening, that means we have a 98% chance of XYZ not happening. Yeah. So we have to look at it from both sides, and then individually, that individual person has to say, what odds do I feel more comfortable with? And the answer is not going to be the same for every person. But for me, like, knowing my body, knowing my pregnancy, knowing my past pregnancy too, knowing that, like, for example, my mother's pregnancies were on the longer side, like taking into account those things, as well as working with a provider that I trusted, staying in touch with my provider very frequently towards the end of my pregnancy, I felt comfortable going past 42 weeks for my own individual pregnancy. But again, like, that was a very, very individualized decision. That's not something that I think everybody would be comfortable with. And that's fine. It's just very much about taking into account, like, the evidence-based decision-making process, which is the research, and then a provider recommendation, and then your own individual priorities and preferences, and figuring out how they all fit together so that you can make a decision that feels right to you. And that's what felt right to me, was to continue being pregnant for really what felt like a really long time.
Oh, it would have been so long. Although your first birth is like a perfect example of what happens so often when we try to have a labor before the body's ready. Like, it just does end up being prolonged and just being a bit more awkward and not fluid and not progressive. And it's just a perfect example. So I'm so stoked to hear about that. And I hadn't heard of that evidence-based decision making that you talked about. And it's funny because I actually teach something very, very, very similar in my birth workshops. But and also, I don't know if you've read the book How Why Induction Matters by Rachel Reed.
No, I have not read that. No, but phenomenal. I do love Rachel Reed, though.
Well, I was lectured by her at uni, and it's always like my little claim to fame moment because I freaking love her. Isn't she just so cool? And yeah, I love all of her books, and her induction book goes into a really great decision-making process in regards to induction. But I love that whole taking into account your own values and what you're comfortable with, and with your partner as well, and what you guys are willing to risk, because with every, day older that you're maybe potentially increasing that risk of having a stillborn, you're also got to take into account the risk of an induction, because that is a risk in itself, and it does increase risk of, epidural, instrumental births, cesarean sections come with all these risks of their own. So it is important to consider. It's not like a pride thing completely. It is very much weighing up the risk but first benefit of both.
Yeah, and I love that you touched on that, because far too often induction is suggested as if it has no risk associated with it. It's like we have risk going farther into pregnancy, but we can avoid that risk by just being induced. But then the conversation doesn't include risks of induction. And so I think that that's really important for people to realize. And that's why, again, like, there's no right or wrong. It's about what risks do you feel most comfortable with, and under what circumstances are you making these choices too. Again, like, if there were all sorts of red flags in late pregnancy, well, then it might make more sense to, like, if I was 42 weeks pregnant and had a whole bunch of red flags coming up, well, then that would be something to consider for sure in my decision making. But, again, like, an individualized approach and weighing out risk and benefit of every option is really important.
Love it. So much good stuff. Thank you so much for coming on the podcast, Britt.
Oh gosh, you're welcome. I feel like we could just keep going on and on. I love having conversations like that.
Forever. I always find, doing the birth workshops and talking to the mamas, they often pose very fantastic questions that I don't know the answer to. So when a few more stock up, I'll hit you up again, and maybe we can have another podcast.
I would love to. And by no means do I have the answers necessarily, but I do love to talk through it. And I think it's just so fun. And there's just always so much more to learn, and just so much to learn from each other too. And when we're talking, and it's been great. Thank you for having me.
Absolutely. My pleasure. Have a wonderful workshop tonight, and I'll talk to you later on.
Thank you so much. Bye.
Bye.